Hello. Welcome, everybody. We are so excited to have you all here. Pretty incredible to look out and know that each and every one of you have been impacted by heterotaxy in some way. So we are just thrilled to have you. For those of you that don't know, my name is Nisha Monroe. I am the president and co-founder of Heterotaxy Connection. Would love to introduce my board members. Allie is in the back. She's our vice president. We have Abby up front. She helps us with our marketing and our press. And then Heather Shreves takes care of our online community. And Heather Williams in the back. She is my co-founder, my partner in crime. She will be stepping back to take care of her family, but we are so excited to have her here. And then we have our newest board member, Monica Bloom. So, yay! So, surprise, yes, surprise for her too. That's what you get for coming to the conference. You never know what I might ask you to do. But, so without further delay, let's get started. Dr. Ware will be, unfortunately, was not able to join us in person, but she will be conferencing in. She has been phenomenal in our own journey. I have a 13-year-old daughter with heterotaxy. She has been very instrumental in helping me figure out the puzzle that is my daughter. So I am thrilled to have her be able to share her knowledge with all of us and to share the advances in heterotaxy. So let's get going. Allie, what's our friend's name? Chris. Thank you, Chris. Do we have Dr. Ware? Oh, there you are.
Good morning. Can you guys hear me? Yes. Okay. Good. Well, thanks very much. I'm sorry I'm not able to be there in person, but really appreciate the opportunity to talk to you. And I'm a clinical geneticist and have had a longstanding interest in heterotaxy, both from a clinical standpoint as well as a research standpoint. So what I'm going to talk about today really is the genetics of heterotaxy, and we'll go over what that means in terms of workup and evaluation for children that have heterotaxy, and then I'll talk a little bit about some of the research that we're doing to try to understand more about the genetics of this condition. So to start out with, my lab studies congenital heart disease, and in a clinical role, I've developed a cardiovascular genetics program here where we're really trying to standardize the approach to babies who have congenital heart disease. And obviously, with heterotaxy, congenital heart disease is one of the big components of that. So this table is just to show that congenital heart disease really has a strong genetic component. And this is based on a national study that was done in Denmark that spanned really 4 decades, where they looked at anyone in Denmark who was born with any kind of birth defect. And so this table is specifically focusing on heart defects. And then over that 40-year span, they looked at how many families had a recurrence of the same type of heart defect. And what you see on here is that there's a couple of types of heart defect that have a higher relative risk or higher recurrence risk than other types. And kind of right at the top of that table is heterotaxy with the highest relative risk. So that means that even though it's relatively rare to see heterotaxy recur within families, it has a pretty strong genetic contribution to it. And some of the other types of heart defects that have a strong genetic contribution include atrioventricular septal defects, and then left-sided and right-sided defects. And when we think about genetic causes of congenital heart disease, based on epidemiologic studies where it really just looks at the population, what we know from kind of a large study done in the United States back in the 80s was that about 3/4 of the cases of congenital heart defects have a genetic etiology, but it's a complex etiology. And then about 25%, or 1 in 4 times, there's a clear identifiable genetic cause, and that can be chromosomal, it can be a single gene disorder, or it can be a syndrome. So we've been pretty good, I think, for a couple decades now at identifying this quarter of the pie where there's Down syndrome that's associated with congenital heart defects, or some other genetic syndromes that are associated with heart defects. Trying to understand the genetic contribution to the other 3/4 of the cases has been a little more challenging. And I think for heterotaxy, heterotaxy falls into both of these categories. And one of the things that's a little surprising is that even for as long as we've known that heterotaxy syndrome exists, we can't really answer easily the question of, well, how many of those times is it due to more complicated or combinatorial genetic interactions versus it's one single cause of heterotaxy. So there are some guidelines for our profession, both for cardiologists as well as for geneticists, that really outline why is it important to even pursue a genetic diagnosis in the first place. And so one of the reasons is that there may be other important organ system involvement. And obviously that's the case with heterotaxy, where you have a lot of organs that are affected. And sometimes you can have individuals who may in infancy just be diagnosed with a heart defect, and actually the fact that they have heterotaxy might not get identified until later in life. And there are some difficulties in terms of really from physician to physician having a common understanding of what the definition of heterotaxy is. So second reason is that there may be prognostic information in terms of clinical outcome. And certainly we know, for example, with heterotaxy, that if you compare someone with heterotaxy versus someone with the exact same heart defect without heterotaxy, the clinical outcomes may be slightly different in those two subsets. So it's important to differentiate. And then there may be important genetic reproductive risks. And, you know, I see this commonly when I see patients or families that have been affected by heterotaxy, and they want to know what caused it and what's the likelihood that I'll have another child with heterotaxy or with some other kind of birth defect. And then if I have other children, what's the likelihood that they're going to have children with heterotaxy or some other type of birth defect? And so in order to really be able to answer those questions with the most accuracy, we need to try to understand what the genetic contribution is within that particular family. And then finally, there may be other family members for whom genetic testing is appropriate. So I think all four of these reasons, they're kind of broad reasons for all types of heart defects, but they do apply specifically to heterotaxy as well. So heterotaxy is a disorder of laterality. And as I said, I have a research laboratory that studies this as well. And we study it in terms of developmental biology. And so what we think about is during development, before the organs even form, you need to have a blueprint for how those organs are going to form. And you need to have a blueprint for how they find their way to where they're supposed to reside in the body. And so the way that the body does that is through establishing a blueprint from a genetic standpoint. And that blueprint basically has a midline, and then it assigns a left side as being left and a right side as being right. And so during development, then the organs align themselves so that the heart is on the left side of the body, the liver is on the right side of the body, the stomach's on the left side of the body, so that the organs align themselves to that left side and right side. And what we know from a lot of work done in really using animal model organisms is that there's a whole pathway, and I'll talk about that a little bit in further slides. But there's a whole pathway for setting up this left side versus right side. And if that doesn't happen completely appropriately, then the organs don't know exactly which side to align to. So this is just a picture of what the organs normally look like in the body. And then there's all different flavors of abnormalities in terms of laterality. So you can have complete reversal of the organs, cytosine versus totalis, where everything's in its right place. It's just kind of mirror image of itself. You can have what's called left isomerism, where basically you have two left atria. You have lungs that look like they're left-sided lungs, so they have just two lobes on both sides. And then the liver may be in the middle of the body, and then you may get multiple spleens, and those multiple spleens may function or they may not function. You can also have situations where just the organs in the chest are flipped, or just the organs in the abdomen are flipped. And then finally, there's what's called right isomerism or asplenia, where basically there's two right sides. There's lungs that both look like they're right lungs. There's two right atria. Again, you may have a liver that's in the midline, and you may have no spleen at all. And then, of course, there's more complicated situations than this. This is sort of the textbook view of it. But in reality, you can get all kinds of different combinations of where the organs are aligning. And because the heart is really particularly sensitive to these left-right cues during early development, you can get a wide constellation of heart defects that result in heterotaxy. And that's shown here. So this is a really overwhelming slide, and that's sort of the point of it. The point isn't for you to be able to really take home any specific information from it, but really to just look at how much information there is on it, and that these are all of the different types of heart defects that you can see in heterotaxy. So there's not just one heart defect that's very specific for heterotaxy, but rather there's this whole range of heart defects that you can see. And then what you see over here, if you just focus on kind of this heterotaxy column, is that in most cases, like over 80% of the time, the heart defects in heterotaxy are complex. Less than 10% of the time, you see simple heart defects. That would be something like just a simple atrial septal defect or a simple ventricular septal defect. And then a little bit less than 10% of the time, you have no heart defect at all with heterotaxy. So the heart defects in heterotaxy are very heterogeneous, and then they're also very complex typically. So what about the genetics of heterotaxy? If you studied anything about genetics in school, you may have heard about X-linked inheritance, autosomal dominant, or autosomal recessive inheritance. Basically, any inheritance pattern that you may have heard about, you can find an example of that in heterotaxy syndrome. Our lab has studied for a long time an X-linked form, which means that typically females are carriers and then the males are affected. That's caused by mutations in a gene that's called SIK3, autosomal dominant, autosomal recessive. Complex inheritance, where you can get mutations in two or typically more than two genes. And then you can have things that happen for the first time, new mutations that occur for the first time, really at the time of conception. And in terms of what we have to offer clinically now, I'd say 10 years ago, we really didn't have much to offer clinically in terms of testing for heterotaxy. And then we had the ability to just test for the gene SIK3. Well, now there's panels out there from a number of different commercial genetic testing laboratories. A panel with 33 genes, a primary ciliary dyskinesia panel that we'll talk about with 75 genes, a ciliopathy panel with 122 genes. So there's a lot of genetic testing that's out there and available clinically. So when I see a newborn, an infant with heterotaxy, from a genetic standpoint, I think about kind of four basic categories of disorders. And we'll go through each of these. So one is a group that we call the ciliopathies. It's a group of disorders of primary or sensory cilia. And these ciliopathies typically don't have congenital heart defects or laterality problems associated with them, but probably less than 10% of the time they can. So it's something you always have to think about when you see a newborn with heterotaxy is, could this be caused by a completely different syndrome, a ciliopathy syndrome? And then there's primary ciliary dyskinesia, which is a motile cilia disorder, which we'll talk about in a little bit more detail. And I know that Dr. Shapiro is there as well. So he's been kind of one of the leaders in this area and identifying really what the interplay between primary ciliary dyskinesia and heterotaxy is. And then a third kind of broad category is heterotaxy that's associated with either a chromosome abnormality like trisomy 13 or trisomy 18, or a small piece of a chromosome that's missing or extra, like we see in a condition called 22q11.2 deletion syndrome. And then final category, which is the most common thing that we see, is isolated heterotaxy. And of course, heterotaxy isn't isolated because you're having abnormalities in all of these different organ systems that occur, but isolated meaning from a genetic standpoint, it's not associated with any other genetic condition. So the first three categories, you might think of these sort of as heterotaxy plus. So they're heterotaxy, but then you have these other things going on as well. And the fourth category is kind of only heterotaxy. And differentiating these four possibilities is really important because what you would do from a management standpoint is different in each of these four different categories. What you would say about recurrence is different in each of these four categories. And probably the prognosis is different with the four different categories. So let's talk about cilia because cilia are very strongly associated with heterotaxy. They're not the problems with cilia aren't the only cause of heterotaxy, but they're a cause that we know quite a bit about. So there are different types of cilia, and they're shown here with some nice kind of high magnification images. So this is an example of what we call motile cilia. So if we had a movie camera on this, you would see these cilia moving back and forth pretty quickly. And if you look at kind of a cartoon version of it, you have a single cell that's got a lot of cilia clustered on it. And then if you do a really high magnification view of cutting that cilia right through the middle, if you think the cilia kind of looks like a blade of grass, and you cut that blade of grass right across the top and look down into it, this is what you would see. So you see this arrangement of 9, what we call microtubules, and then in the middle, there's this central pair of microtubules, and these are what's important for helping the cilia beat. So these are motile cilia. So then there's a second type of cilia, which sort of unfortunately are called primary cilia. And I'll talk about why that's unfortunate in a minute. But these are really, as opposed to being motile cilia, these are sensory cilia. So instead of being a bunch of them on a cell, there's only a single cilia on each cell. And it doesn't move. And part of the reason it doesn't move is that it's got these same 9 pairs here, but it doesn't have all the little arms sticking off of the pairs, and it doesn't have the central microtubule. So they don't move. There's one on a cell, and what they do is they sort of sit out there and they sense the environment, sense the fluid around it, and then they give signals back to the cell, tell it what's going on outside of it. And then finally, and this is most important for heterotaxy because this is what some of the main causes of isolated heterotaxy. It's a very special kind of cilia. So you can see this cilia is a little bit different. There's only one per cell, and it sticks out there, and it senses the environment, but it actually moves. So this one cilia per cell, it rotates in a counterclockwise direction, and it pushes fluid around. And the other reason that this is a very special type of cilia is that it's present only for a short period of time during embryonic development, and then it goes away. And in that short period of time that it's present during embryonic development is a stage at which there's this thing called the embryonic node, which is shown here. It's sort of a teardrop shape, a little pit or depression where you've got cells with one cilia per cell. And this is occurring right at the phase of development. It's kind of around 3 weeks, most of the time, right at the time people learn they're pregnant or right before they even know they're pregnant. And it's when that blueprint is being set up in the early embryo and the left side is being established as left and the right side is being established as right. So these cilia are there during that time. They help the left side and the right side get set up, and then this goes away. So diseases of the primary cilia, this is kind of that first category that I talked about, the ciliopathies. And there's a whole different group of conditions that are called these sensory ciliopathies. And they have a lot of medical problems associated with them. So all of these in yellow are liver or kidney problems that are associated because of problems with this sensory or primary cilia. You can have problems with the central nervous system, something that's called Ware syndrome, that's got central nervous system abnormalities and Meckel as well. You can have problems with bone development and the skeleton. You can have problems with diabetes and the development of eye problems and development of diabetes, conditions called Alström syndrome and Bardet-Biedl syndrome. And all of these conditions are pretty distinct genetically, but about 10% of the time they may have a laterality disorder or heterotaxy associated with them. So again, if I'm evaluating a newborn with heterotaxy, I need to think about all of these kinds of things and look to see if there's any evidence for any of these conditions in addition to heterotaxy. So then that second category, one more thing on this is just to show you the range of other defects that you can find in this. As I mentioned, heart disease, liver disease. You can have significant intellectual disability associated with some of these syndromes. You can have extra digits, extra fingers, or extra toes. And what you can see here is that these left-right defects or heterotaxy are associated with a lot of these different syndromes. So then the second category, so that was the ciliopathies. The second broad genetic category that we think about is primary ciliary dyskinesia. So the reason that I said that term of primary cilia for sensory cilia is unfortunate is because with primary ciliary dyskinesia, you might think, okay, well, that's a problem with the primary cilia, but it's not. It's not a problem with the primary or sensory cilia. It's a problem with the motile cilia. And the reason it's called primary ciliary dyskinesia is because to differentiate it from a secondary problem with your motile cilia, like something like smoking. So if you smoke, you injure the cilia that move in your airways, the ones that are in your airways that kind of help you move mucus and phlegm out of your airways. You do damage to them if you smoke. So that's an example of a secondary ciliary dyskinesia. So this was called primary ciliary dyskinesia to say it's primary. It's something that's wrong with the cilia itself. It's a structural problem. It's the genetic problem with the cilia. But it's actually not a problem with primary cilia. It's a problem with motile cilia. So very confusing, but it comes from different medical specialties, not realizing that things were going to end up being related down the line. So primary ciliary dyskinesia is a very well-defined clinical condition, and as I said, I know that Dr. Shapiro is there, and we'll probably be talking about this more. But it was originally associated with heterotaxy in this paper back in 2007, where they showed that individuals with primary ciliary dyskinesia, where it had long been recognized you could get situs inversus totalis occurring, they recognized that congenital heart defects also occurred in these patients in at least 6.3% of those patients. And then Dr. Shapiro went on and did a follow-up study that kind of upped that estimate to about 12.1%. And then he's been one of the few people that has looked at through kind of a phone and print survey that he did, I think with the help of Heterotaxy Connection, looking at just responses from families that had individuals affected with heterotaxy to try to determine what really is the overlap between heterotaxy and PCP and how many patients with heterotaxy also have a diagnosis of PCP, and from a genetic standpoint, that's the explanation. And I think we still don't know the answer completely to that question, but it may be as high as 1 in 3 individuals with heterotaxy that have either primary ciliary dyskinesia or have some other ciliary dysfunction that goes along with their heterotaxy. And this is really important from a management standpoint because there are specific things that you want to do to manage the ciliary problems. So management, what do you do in terms of management with heterotaxy? Well, I'm sure many of you know and have experienced that there are multiple subspecialists that are involved in the care of heterotaxy. So obviously, because heart defects and complex heart defects are so common in heterotaxy syndrome, the medical and surgical management of cardiac malformations is really important. And in fact, the long-term prognosis of an individual with heterotaxy is primarily dictated by the type of heart defect that they have and their surgical outcome with that heart defect. And that's part of the reason that it's very hard to give prognosis estimates in individuals with heterotaxy because each individual is very unique and their the specifics of their malformations is really going to dictate what prognosis and outcome is. So the medical and surgical management is really important for that. In newborns with heterotaxy, we always recommend head and abdominal and renal ultrasounds. Part of that for the abdominal and renal ultrasound is really to define the anatomy, to know in terms of the sidedness of things. The other is really, as I mentioned with the ciliopathies, you want to know if there's any other malformations that would make you think about some of these other genetic conditions. For example, is there anything abnormal in head ultrasound that would make you think about that Ware syndrome or some of the other genetic syndromes that can have some central nervous system malformations as part of it. Defining the spleen is important. Is the spleen present or absent? Are there multiple spleens that are present? Different institutions have different protocols for how they more formally assess the function of the spleen. But I think it's important to emphasize that the function of the spleen should always be in question in individuals with heterotaxy. Even if you see a single spleen, that may not mean that it's functioning appropriately. And that's important because the spleen is important for protection from infection. You should do assessment of the gut to make sure that there's not malrotation present. And again, different institutions are going to have different protocols, both in terms of how they do that evaluation, and then in terms of if they identify that malrotation is present, whether they decide to do anything to correct that or not. I think that there's, it's still a little bit of a debate in the literature in terms of whether you should intervene if you see malrotation or if you should just note it. And then assessment of pulmonary status and determination of whether primary ciliary dyskinesia is a concern or not. And then I think genetic evaluation, genetic testing, and recurrence risk counseling are really important for heterotaxy syndrome. I will say that many institutions do not have really the personnel in place to do this or to do this well, but I think it's increasingly an important part of the evaluation for patients with heterotaxy. So I mentioned that there is clinical genetic testing available for heterotaxy, and what do we recommend be done? So in an infant or young child with heterotaxy, I always recommend chromosome microarray analysis be done. And then there is more specific testing that can be done, heterotaxy gene testing for SIC3, the X-linked form. I think this is very important for families that are considering having additional children because it very much changes what we would say about the recurrence risk. So if the testing for SIC3 is positive, then there's going to be a 50% recurrence risk for future male children. And then if the testing is negative, then it would be more of the empiric recurrence risk, which is around 5%. So that's a pretty big difference, 50% versus 5% recurrence risk. I think testing for PCD genes is important. We now have that in place as a standard here at our institution that we do molecular testing for that in infants with heterotaxy. And then consider testing for other ciliopathy genes, I think, depending on the clinical picture. So I thought it might be useful to really go through the different flavors of genetic testing because, you know, this is sort of a list of tests, but to understand how these tests are being done is sometimes helpful and sticks a little bit more in terms of understanding the approach. So just to kind of cover the basics of genetics, our genetic information is packaged into chromosomes. And we have 22 pairs, and then the 23rd pair, it's a pair in females, XX, and not exactly a pair in males, XY. These are the sex chromosomes. And so when I talk to families, I often talk about the fact that this genetic information is packaged into these chromosomes, and you might think of them as books. So our kind of broadest genetic screening that we can do is just a chromosome analysis where we look to see are there abnormalities in chromosome number. We can count them and we can stain them so that we can look at a specific pattern to see whether they're normally stained or not. Then if we go down to kind of the next level of resolution, so if you look onto these individual chromosomes here. This is what they look like when they're stained. You get kind of this striped pattern. And on those chromosomes are genes. So we can look to see at the chromosome level, are there pieces of chromosome that are missing? Are there pieces of chromosome that are extra? And then if you drill down yet again, looking into these individual genes, then you get down to what we call the DNA strand and the individual base pair level. So each kind of rung on the ladder would be an individual base pair, and that's looking for kind of at the DNA level, looking for mutations of the DNA. So that's kind of the broad overview of how our genetic information is packaged. So like I said, when I talk to families, we have two broad flavors of genetic testing. We have kind of the chromosome-based and then the molecular or DNA-based. And there are different ways of approaching genetic abnormalities. So this is chromosome microarray testing. And if you think about the genetic information as being arranged in books, then this would be basically looking at the pages on the books. And so we can say, is every page that's supposed to be in this 46 volume encyclopedia, is every page present? Are there any pages that are missing or extra? And this testing became available in about 2005. And subsequent to that, there have been a number of position statements from kind of our governing body, the American College of Medical Genetics, the Obstetric and Gynecology governing body, ACOG, that really dictate the chromosome microarray, when it should be done. So in a prenatal situation, when should it be done? Postnatally, our position statement is it should be done in babies who have developmental disability. It should be done in babies who have congenital anomalies. So obviously heterotaxy is a congenital anomaly syndrome, and I think that there's support for chromosome microarray testing being done in every individual that has heterotaxy. So molecular genetic testing then doesn't look at the pages. It can't tell you if all of the pages are there or if there's any pages that are missing extra. But it kind of goes at a different level, and it can tell you the individual words on a page. Are there any words that are misspelled or not? And then the highest level of that is what we call an exome test, and I'll talk about this in terms of our research. And the exome test is really looking in that entire 46 volumes of the encyclopedia. If you look at every word on every page of all of those volumes, that's what an exome test is. So it's basically sequencing of about 20,000 genes, and it's looking at the spelling of each one of those genes. What it's not doing, it's not looking at the grammar, it's not looking at the spacing, it's not looking at the syntax or anything like that. So it still doesn't pick up every possible genetic condition, but it does test for an awful lot. So copy number variation in heterotaxy. So I mentioned on chromosome microarray, you can get pieces that are missing or pieces that are extra. And this is just an example of if you're missing this little block of C, what the chromosome then looks like, or if you have a block of C that's extra. And this is important. It can disrupt genes and cause abnormalities because of that. So what do we know about copy number variation in congenital heart defects and then in heterotaxy? So we know that about kind of a broad range, but about 3 to 25% of congenital heart defect patients that also have another organ system affected will have a copy number variant that explains their heart defect. And then if you look at individuals that just have heart defects with no other extra cardiac defects, about 3 to 10% of patients. There's this additional study that we did that looked more specifically at patients with heterotaxy or heterotaxy spectrum heart defects and identified 45 copy number variants with 39 patients. So about 15% of patients had a copy number variant. And then a final study that looked at 74 patients that all had kind of classic heterotaxy syndrome, and they found about 26% of those patients that had copy number variants. So probably somewhere between 10% and 30% of individuals with heterotaxy will have a copy number variant that explains and provides the explanation for their heterotaxy. So then what if we look at the other type of testing, the molecular type of testing? This is really old now. This is back in 2009, but I'm not aware of a more up-to-date review that's been done yet. And this sort of looks at PCD as causes and then other single gene causes of heterotaxy. So we know that probably, we've upped this now, probably in about 3% of sporadic cases, there'll be a SIG3 mutation, and then in where you have recurrence in families, about 75% of those will have a mutation in SIG3 that explains heterotaxy. And I've already mentioned for primary ciliary dyskinesia, we don't know exactly how many individuals with heterotaxy have a genetic change in the gene that causes PCD is the explanation for that. But probably somewhere in the neighborhood of 5% to 30%. So this is sort of what we think is going on. If you do the CMA, somewhere between, I'm going to adjust this down to about 10% to 30% will have an abnormality that explains the heterotaxy. If you do clinical sequencing for the SIG3 gene and looking for the genetic causes of PCD, you'll probably pick up another 10 to 20%. So that still leaves the majority of patients with heterotaxy that we don't identify. We know it's genetic, but it's probably more complicated genetics and combinatorial interactions that explain it. And the way we've been thinking about this more recently, and I'll show some of our research results, is that there is probably a combination where maybe you inherit 10 or 15 small changes in genes that are important for this development of the left-right blueprint during early development. And you really have to inherit all, 10 or 15 of those. And if you only inherit 5, you may have, sort of a susceptibility, but you don't reach that threshold to actually develop heterotaxy. So that's kind of the way that we're approaching it now. And so from a research standpoint, then we think about, well, what do we know in terms of development? What do we know in terms of left-right development? So I talked a lot about cilia. We know that cilia are important for development. I haven't really talked about cell polarity defects at all. So this shows the cilia. What cell polarity means is basically positioning of the cells in relationship to each other, and then positioning of, in this case, cilia within the cell. So I mentioned during early development, you have this node structure that's present, and then when the left-right blueprint is set up, and then it goes away, and that there's this one cilia that beats in that counterclockwise direction. So that cilia actually starts out at the top of this dome of the cell, and it's got to move backwards so that it can be at a tilt. And it's really important that it be tilted because that's what helps it generate the gradient of flow that is developed. So that requires cell polarity. That's sort of the developmental biology term for this migration backwards. So we know that the genes that are important for that migration can also cause heterotaxy. And then finally, we know this pathway important for setting up the left side versus right side. There's a lot of signaling that occurs. This gene nodal and developmental pathway called the TGF-beta pathway is really important for setting up the exchange of information on the left side of the body. And so we know that genes that are in these signaling pathways are important contributors to heterotaxy. And we've done a lot of work in mouse models, but when we look in humans, we don't see very many humans that have mutations just in these genes. So our working thought about that is that it's probably too severe that if you completely knock out this gene, probably the embryo can't develop into a fetus and then be born. And that was what led us to our thought that, well, you can't get rid of it. You can't take it from 100% function down to 0% function. But if you took it from 100% function to 90% function, then, that's survivable. But if you combine 90% function of this gene nodal with 90% function of this gene lefty with 90% function of PEDX2, maybe it's that accumulation of just slightly decreased function and all of these things in the pathway that actually then give you that susceptibility to heterotaxy. So I'm just going to show this one slide. This is the from a mouse embryo. And this is showing again, this is in the mouse embryo, the development of this structure that's called the node. This is in a normal mouse embryo. It looks like a teardrop. You can see it down here with some staining, fluorescent staining, that it looks like a teardrop. And when you get rid of this gene SIG3, we knock it out in the mouse, what you can see is we don't get a normal formation of that teardrop, and that's a cell polarity problem. So instead of getting a nice teardrop, you get kind of 3 clusters of cells instead. And then the cilia, we think, may not work or form completely normal. So this is just an example of how we can use animal models like mouse to really help us better understand what's going on in patients that have heterotaxy, and how did this gene even cause heterotaxy in the first place in those individuals that have SIG3 mutations. So I just kind of want to finish up with the genetic studies that we've done. And I think, Heterotaxy Connection has been really generous in posting the availability of to enroll in our research studies on their website, and encouraging individuals, kind of referring individuals who are interested in participating in research to our study. So I wanted to show you some of the results that we've been able to do with people that have enrolled in the study. So I gave you some of the results that we had in terms of kind of the copy number variants already, but this shows it just in more detail. So we started out with a set of 225 patients with heterotaxy or heterotaxy-related heart defects. And we looked for copy number variants in those individuals, and we found about 20% that had rare copy number variants that you don't see in the normal population, and about 80% that had kind of common copy number variants. And of these 20%, 7% of them were what we would be called clinically relevant. They clearly explained why the patient had heterotaxy. And then about 13% of them are very interesting from a research standpoint, but not quite so clear-cut in terms of absolutely being disease-causing and or the absolute explanation in the individual. So of those 30, we looked at all of the genes that are present within those 30 and found 165 genes in total. And then we prioritized some of those to study further in our model organisms. So we've used Xenopus, which is frog, as a kind of higher throughput model organism, more high throughput than mouse, because we can study them in 5 days, as opposed to in mouse, it takes us about a year to make the mouse and then to really analyze the embryos. So we use frog, and we can look at the heart. This is an example of what a heart looks like in frog, a normal heart, and then a reversed heart. The V there is for ventricle. And then we look to kind of mimic heterotaxy, which has multiple organs involved. We don't just look at the heart, which is kind of shown in pink here, but we also look at the position of the gallbladder, which is shown with the green dot. And then we look at the position and the coiling of the gut. And the gut's coiled kind of in just similar to human gut, actually. It can be normal, or it can be reversed, or it can be more complicated forms of reversal. So we look at these genes that we think are maybe good candidates for heterotaxy. We decrease their function in Xenopus, and then we score them to see whether these things are abnormal. So this is just an example of some of the genes that we've identified as candidates. We've published this one, PFKP, where we've shown that if we knock that down in Xenopus, that it's abnormal. And it's in a new pathway. It has to do with the regulation of glucose in the body. So we're very interested in kind of identifying some pathways that may be involved in the development of heterotaxy. So this is what I showed before, the 225 patients. I showed that there were these that had common CMVs that we didn't identify candidate genes. So for those, then we've gone on and we've done some additional genetic research on those using this exome-based testing that I explained looks at all 20,000 genes of patients. So these patients, we actually, when we did the exome, then we increased, because we've had more families that are enrolling. So we increased the number that we looked at from 225 up to 285, and we did exome sequencing on all 285 of those individuals. And just in terms of the kind of the constellation of things in terms of the patients that we've had enrolled in our study. Almost exactly half what I would say classic heterotaxy, so malposition of multiple organs. And then we've got about 20% that have just a congenital heart defect, but it's of a heterotaxy type. We have 13% that are cytosine versus totalis. We've got about 13% that they just sort of enrolled as heterotaxy, but we don't have more detailed clinical information on them. And then a small subset that are sort of this acronym factorial that meet definition for heterotaxy, but may have limb or skeletal or other defects as well. So that's our 285. So we did sequencing of all 20,000 genes, but it's really hard to just start analysis of all 20,000 genes. So we have to start somewhere. So we started by looking at these 170 genes that are available for clinical testing. So if these patients had had clinical genetic testing in the most comprehensive fashion that was available with the different panels, this is what they would have had 170 genes done. So a ciliopathy panel, cytosine versus panel, laterality panel, and PCD panel. So what did we find in our 285 patients? So this is kind of a complicated slide, but it basically shows the different genes that we found abnormalities in, and it's a little bit easier to look at the color coding. So pretty much anything that's in yellow is an individual that we found. If you remember those 4 categories I outlined in the beginning, anything in yellow is either the ciliopathy syndrome category or the PCD category. Anything that's in red is really in our X-linked category. So there's SIC3 mutations, or now we think we may have identified a new gene that causes X-linked heterotaxy. It's a gene that's known to cause other things, but nobody's ever described it with heterotaxy before, so we're doing some more research on that. And then a number of patients that had single changes in genes that we know can cause syndromic congenital heart defects. So when we look at this all together, and we look at, well, of those 285 patients, if they'd had clinical genetic testing done, what percent of heterotaxy would we have identified with a problem? And it comes down to being almost exactly 15% of individuals have a clinically relevant, basically clear explanation for their heterotaxy by exome sequencing. And really interestingly, when we looked at those that had some type of family history of heterotaxy versus those that had really no family history of heterotaxy, the yield is almost the same. So this was very surprising to us. It sort of doesn't depend whether you have a family history of heterotaxy or not. Our yield by exome testing is close to 15%. So I think this is pretty good. I mean, compared to where we have been with heterotaxy, to be able to say, 15% we can identify the cause for heterotaxy is a lot better than it was 10 years ago. But obviously that still leaves 85% that we don't have an explanation for. And so we've been pursuing this idea that we're not going to be able to identify it by looking at a single gene, but we have to begin to get at this combination of genes. And the way you have to do that is statistically. And statistical genetics are a very arrogant bunch when it comes to numbers. So unfortunately, heterotaxy is a rare disease, and statistical geneticists, they like to study things on the order of 100,000. If you have 50,000 patients, if you have 100,000 patients, then you're starting to get to that threshold of really being able to say that you feel confident about something. Well, obviously for heterotaxy, we're just never going to have those kinds of numbers. So I think we have to be a little bit more creative in our approaches. And I think that's where trying to find something in patients and use the statistics that we can have from the numbers that we are, and then combine that with our animal models is really the way that we're going to have to approach answering these questions. So each disease is different in terms of this, when you look at complex genetics and combinatorial interactions. But congenital heart defects, we do think has a very strong genetic component, even though we know there's an environmental component as well. So going back to the mechanisms of heterotaxic disorders in these 3 categories, we tried to say, okay, well, we still can't look at 20,000 genes all at one time. That's just way too complicated from a modeling standpoint, but we want to move outside of these 170 genes. So can we come up with something between 170 genes, but smaller than 20,000 genes if we look at genes that are important in these kind of three broad groups? And so we did that. We did that, and we came up with 2,293 heterotaxy genes. And this is kind of the databases that we got them from. So you can see 46 genes are in all of these different databases, but there are some of these genes that are only present in one of the databases. And this is how we went about our analysis. So we have to compare to something. So we have 285 patients with heterotaxy, and what we want to say is, in each individual with heterotaxy, we don't want to just look at one change, but we want to look across these 2,293 genes, how many have multiple changes in these genes. And the idea of having a susceptibility would be, if you compare heterotaxy patients compared to individuals that don't have heterotaxy, they would have more changes, they would have a higher burden of changes in these 2,293 genes than individuals who don't have heterotaxy. So we're going to be comparing burden, gene burden, basically. And so we're comparing to a database that's called the 1,000 Genomes database, which has 2,504 participants in it. So those are our controls. And we're looking just for single DNA changes, and then we're only looking for changes that are rare, that occur in less than 0.1% of individuals. So we're assuming that things that are common are not the cause of heterotaxy, that you have to have things that are rare. And then we're just doing kind of a prediction of whether those rare changes might cause damage to the protein or not, and then comparing them statistically. So we wanted to do this kind of with controls first. So we're comparing our patients with a control, but then we want to look at 2,293 genes that don't have anything to do with heterotaxy. So we started this by looking at autism genes. We don't think autism genes have anything to do with the heart development and the positioning of the liver and spleen and so forth. So we would expect that if we look at the burden in heterotaxy patients in these 2,293 genes versus our control population, that we should see no difference. And in fact, that's what this shows here, that overall, from a statistical standpoint, there's no significant difference between our heterotaxy patient and controls. So now that's good. So now if we look at these 2,293 candidate heterotaxy genes, do we see any statistical evidence for difference? And in fact, we do. Looking overall in our 285 patients, we see a very high p-values, a very high statistical significance, that there's more changes or more burden of DNA variants in our patients with heterotaxy than we see in controls. And then we can break that out and we can look at just that 50% that sort of had classic heterotaxy, and we see statistical significance there. If we look just at our group that has congenital heart defects associated with heterotaxy, we still see statistical significance there. But when we look at our group that has cytosine versus totalis, we don't see any significant differences there. So this gives us kind of some interesting insights into our candidate genes and what we're looking at. So then finally, so this is a super complicated slide. And it basically is just looking at the different components of how we got our 2,293 genes. I mentioned we got it from a number of different databases, and so we looked by those different databases. And the only reason I show it, because like I said, it's a very complicated slide to show to families, but the only reason I show it is because I think it's really interesting that everything is significant except for this one group of genes. And the one group of genes is genes that we know are important for congenital heart defects, but they don't have anything to do with cilia. And when we look at those in our cases versus controls, we don't see any evidence for statistical significance. I think this is giving us some clues about candidate genes and genes that we can better pursue. So I think we have some statistical evidence now, and our next step is now to take this back to model organisms and try to more in a more sophisticated way, beginning to look at these combinatorial genetic interactions. So in summary, we know that heterotaxy results from abnormal axis development during the development of the early embryo. And we know that abnormalities of cilia are very important and can cause heterotaxy, but there are other causes too. So abnormalities of cell polarity and then some of these developmental signaling pathways are also important causes of heterotaxy. The genetics are really very complex, but I think they're very important in pursuing clinically in patients because they do have management implications. It's important for recurrence risk to know if it's inherited as X-linked, autosomal recessive, or autosomal dominant trait, because that's going to change what the recurrence risk would be. The clinical genetic testing is available, and we don't know the exact yield, but it's probably somewhere around 20 to 40%. I think, a real challenge to us, and one of the things we need to do to move the field forward, is the fact that there's currently no standards for genetic evaluation of heterotaxy patients, and there's no standards for additional evaluation for PCD. And I think that this has this is problems. If you miss a heterotaxy patient that has PCD, you're missing an opportunity for really intervening proactively with important management. So I've tried to show developmental and genetic research studies. I know sometimes these are of real interest to families, and some families aren't interested in research at all. They just want the more practical, tell me what I need to do to take care of my child or to take care of myself if it's an adult with heterotaxy. But because Heterotaxy Connection has been sort of so generous in promoting our research, I really wanted to provide some of the results that we've been getting back to you guys today so that you would sort of see the way that we're thinking about things. And I think, really that's the direction we're going now, is ongoing investigation of this idea that really it's an accumulation of multiple variants or genetic predisposition that is maybe the cause of most of the cases of heterotaxy. And so I want to thank you for your attention and be happy to take any questions. And again, thanks for letting me participate remotely via Skype. I really appreciate the opportunity to talk.
Thank you so much, Dr. Ware. We do have some questions for you. The first one I have actually came from one of our community members who's not here, who's been able to follow along on Twitter while we've been tweeting some of your thing. And they were wondering about when you were talking about other management for when heterotaxy is found, you had mentioned a head ultrasound. That's something that their child has had all of the other testing that you had mentioned, but not the head ultrasound. And they were wondering what specifically you are looking for when you do that.
Yeah, so the head ultrasounds are typically done in infants. Some centers will have a head ultrasound as a standard just for any infant with a complex heart defect. And part of that is it's a screen to make sure that there's no gross malformation. Part of that is we know that infants with complex heart defects are at longer term risk for neurodevelopmental issues, and so it provides kind of a baseline for that, and if there is anything abnormal, they can go back and do that later. I would say in older children, if a head ultrasound wasn't done in infancy and now it's an older child, that is probably not really indicated if there aren't some other medical problems or if there isn't either intellectual disability or some type of significant developmental delay, that it's not necessary to go back and repeat that if you've got a little bit of developmental history to go on at that point.
Awesome, thank you. Other questions? Hold on 1 second. I'm bringing the mic over just to make sure that everyone can that you can hear our questions.
Just to get some clarification, did you mean by age 1 or so for the head ultrasound? Sorry, we're really stuck on that because I'm sitting in a group of us and not a single one of us had a head ultrasound for our child. The only time that we get anything is when they stroke out after heart surgery.
Well, I mean, I think in an under 3-month-old, it's worthwhile doing. By the time you get to 6 months, if you're not seeing any evidence of developmental delay or there's not other problems that are ongoing, and also if the pediatrician or family physician is measuring the head circumference and the head growth has been normal, so the head is not too small or the head is not too big, then there's not really an indication to do on at that point. If at any point in time, I would say if the head of the child is not growing normally, it's either too small or too big, I would do a head ultrasound at that point in time. Or if there's differences in terms of development. It's sort of an easy screening to do at that point. In older children, you really can't effectively do a head ultrasound because you can't get the windows. You need the soft spot present in order to be able to do it. So you would have to be thinking about some more dedicated imaging, either CT scan or MRI at that point anyway. So you do have somewhat of a narrow window, but I would say, under 3 months, if it hasn't been done, I think it's worthwhile to do.
Thank you, because we are parents with checklists. Like we go to our doctors with checklists. Like, these are the things that we think we need to do that we've heard from the Heterotaxy connection. So we just need that clarification to overwhelm our doctors. Thank you.
Hold on, we've got another question coming for you.
Hi, Dr. Ware. You stated something in between talking about PCD and heterotaxy, which I found interesting. My son has another complex left side defect sister, but his dad and 3 other half siblings happen to have extra digits. Can you reiterate on that subject?
On the extra digits?
Yes, I thought that was very interesting.
Yeah, so some of the ciliopathy syndromes, you can see extra digits as a clue maybe for that syndrome. The most typical would be extra digits that are on the thumb side or the great toe side. Less common to see it on the pinky side. It would be more suspicious for some of the ciliopathies or for some other genetic syndrome if you see it on the thumb side, because that's,
So it's actually both, and they have a high history of asthma. So would you recommend that these mothers get their kids checked out?
So I'm having a hard time, there's sort of an echo, so I'm having a hard time hearing it.
So there's a high incidence of asthma in these siblings in a family where there was a lot of extra digits. Do you think that would be something that they should pursue further testing for PCD? Or other?
So hard to say. So asthma are common. Extra digits that are on the pinky side can be common, especially in specific races and ethnicities. I think it's definitely worth having more of an evaluation from a genetics standpoint. Asthma and PCD are pretty different in terms of the signs and symptoms of those. So if there's been a definitive diagnosis of asthma, and, maybe Dr. Shapiro will want to speak to that too, but the signs and symptoms are pretty different between those two. So a diagnosis of asthma doesn't really worry me for PCD. And I think with regard to the extra digits, you don't typically see extra digits in PCD, but you do see in that other category of disorders, the ciliopathy disorders. So they're actually kind of a distinct category from PCD. So I wouldn't put the extra digits and PCD together in my mind, if that makes sense.
Yes, thank you. All right, we have one more question for you.
I am wanting to touch on the idea of structural bone abnormalities, just because our experience with our child is we were given a diagnosis for my daughter as far as her bone growth, and then she grew and that diagnosis disappeared, but we were talking to different people. And so there was kind of this disconnect as far as her having heterotaxy and then also having these questionable bone growth issues. And I'm a little bit lost as to how do we approach that in getting our specialists to look at those as something that could possibly be connected to each other, as opposed to just a child that's growing in a funny way.
Yeah, that's a great question. So, and I guess I have a little bit of a complicated answer to it. I think that problems with bone can also come in different flavors. So there can be issues with the formation of the bone, meaning that either there's extra bones or absent bones, or that there is something wrong with the kind of the size of the bone. So if it's any of those would be kind of more of a structural abnormality, and I think that there should be an evaluation for some genetic syndrome associated with heterotaxy. If it's actually overall growth of bones, then you want to make sure that you're looking at sort of endocrine issues as well as heterotaxy issues. So again, I think that because the causes of heterotaxy are complicated, it's hard to give broad-based answers to specific questions because there's so many different possibilities there. I think a sort of a practical approach to that would be to draw providers' attention to the fact that that heterotaxy is actually related to a lot of other underlying genetic conditions, and the fact that if you're seeing something going on with bones, does that need to be, does your child need to be seen by a geneticist, or does your child need to be seen by an endocrinologist, or does your child need to be seen by an orthopedist, some other subspecialists that would have more knowledge, in sort of the organ system that is the bone, and then ask that subspecialist, can you tell me whether you see a relationship with this heterotaxy? Unfortunately, I'm sure what many of you have experienced is it puts you in sort of the job of the parent is educating the professionals, because heterotaxy is rare and the professional may not be aware that there's this relationship between heterotaxy and bone, or heterotaxy and cilia and ciliopathy and bone. And so can you please think about these two things together, whether they can be related or not? But I think that's one of the reasons that I do, try to advocate for genetics involvement, because geneticists are the one group that try to span that gap and think about how everything going on with the child medically relates. Is there an umbrella explanation for this from a genetic standpoint, and try to help those subspecialists talk to each other, because cardiologists, they know everything about the heart, but they may not think about the relationship to PCB and the lungs. The orthopedists, they know everything about the bone, but they may not think about how that relates to left-right patterning during embryonic development. Why necessarily would they? So again, I know not everyone has access to geneticists. Unfortunately, there's not that many of us out there, and so some centers just don't even have a geneticist available. But if there is a genetics group available, I would push for that, because I think that person can help facilitate that. And if not, I think that families have to begin advocating and trying to help educate the providers and asking them to make some of those connections. So long-winded response, but I think it's an important question, and probably touches on specifics that a lot of the other parents and family members have.
All right. Thank you so much, Dr. Ware. We appreciate you making this work and taking the time out of your clinic today to help us out. For those of us that are here, we do have a paper on the front seats, for those of you that don't like to sit in the front, that details Dr. Ware's latest genetic studies and how to get involved in that. We highly encourage you to look into that. We will also be putting that on our website and sharing that on our social media. So thank you, Dr. Ware.
Thank you.